In this excellent symposium. I would like to congratulate the organizers, particularly Dr. Tranos and Dr. Balidis, for this fantastic work. I'm very glad to be here today. So I'm aware of the fact that you've been bombarded with information, huge amount of information on function, principle, applications of OCT. So it's not my intention to repeat information that has already been delivered. Rather than that, I will focus on the corneal refractive perspective of the OCT and highlight its more relevant implications for the anterior segment. So I have no financial interest. Just to remind you briefly that the first devices performing imaging of the anterior segment were introduced 25 years ago. There are devices dedicated to anterior segment imaging and others facilitating pole-to-pole imaging. They have a wavelength varying from 830 nanometers, like the retinal imaging devices, up to 1,310 nanometers. And the average anterior segment OCT device is achieving an axial resolution of 4 to 6 microns with an excellent scan speed. These are actually the devices that we use in my department: the OptiView, the Cirrus, Visante, the Spectralis, and the new swept source OCT, the Casio OCT, which this technology, as you may know, is dominating now also the anterior segment imaging with its advantages. So I will just mention briefly the applications in the medical cornea area, which are assessment of corneal thinning in corneal ectatic disease, keratoconus, PMD, or Terrien degeneration, assessment of the corneal hydrops in corneal infection, evaluation of corneal ulcer depth, corneal dystrophies, assessment of the deposits and the lesions depth, and evaluation of the size and infiltration in cases of corneal sclerotic tumors. Now, this is a case of keratoconus. You can observe on the corneal thinning, and another case of Terrien degeneration with this marked corneal thinning. And here you see again with the Casio imaging technique the thinning and haze in the case of keratoconus, apical haze and corneal thinning, here the same. Although I have to say that it's not a basic function, the assessment of corneal thinning, what we use these devices for. And here you have a case of, again, of conus, where we perform actually, we use ultra thin, ultra high resolution in order to visualize, like here you can see, it's a prototype device, to visualize and assess the different layers of the cornea. They have an axial resolution of up to 1 micron, 1 or 2 microns, and we perform epithelial mapping because as we know, we have discovered the last 5 years, epithelial mapping is a very valid method for diagnosing form fruste conus, early keratoconus. Why? Because we know that on the area of the cone, we have a certain thinning of the corneal epithelium, which is surrounded by an area, a ring, an annulus of corneal hyperplasia. Of course, most of the ultra high resolution devices are prototypes, are only, if I'm not mistaken, 1 or 2 commercially available devices. But this is a very interesting application used in cases of suspected form fruste conus, which have a corneal topography being in the gray zone, not definite for keratoconus diagnosis. Now, it's also very useful to use in the anterior segment OCT in cases with corneal hydrops, not only for the diagnosis, but also for evaluating the post-treatment course, regardless of the treatment approach that we use, whether it's going to be a conservative treatment approach using steroids, local topical steroids, or anti-inflammatory drops, or maybe gas insertion in the anterior chamber, or murine sutures. We can observe the course of the disease and the regression of the fluid in the corneal stroma and take the best decision for our patients. In corneal infection, it's necessary to use anterior segment OCT when we have deep ulcers in patients who are at high risk of corneal perforation. In every patient with decimatous seal, it's actually obligatory to perform anterior segment OCT. Here you can see it's a case that I showed also yesterday in the clinical cases. It's a case of fungal keratitis with satellite infiltrates, hypopion, and formation of a mycotic retrocorneal plaque. So doing the appropriate treatment in these patients, in this case, after PAC-CXL, we can see that the retrocorneal plaque has decreased. So it's a good metric, actually. It's a good measure for evaluating the efficacy of our treatment approach. And this is a result after the PAC-CXL. I've showed these pictures before. But in any case, it is very useful to have the information regarding corneal thickness and depth of the corneal ulcer. Now, in corneal scar, it's also important to measure the depth of the scar. This is a patient with a perforating injury. And although on the slit lamp we might have some evidence that the scar is going deep to the predecimatic level, we have the evidence on the anterior segment OCT image so that we can adjust our treatment approach and decide on our surgery options. In corneal dystrophies, although we know how deep the lesions can go depending on the type of the corneal dystrophy, it's always useful to perform anterior segment OCT, visualize the lesions, and again, take the right decision whether we will perform deep anterior lamellar keratoplasty or full thickness perforating keratoplasty. This is a case of granular corneal dystrophy with the lesions being deep, reaching the decimate membrane. Now, from the surgical point of view, cross-linking is an interesting area for anterior segment OCT application. Refractive procedures such as ring implantation or phakic IOL implantation, laser-assisted refractive surgery also takes advantage of these imaging techniques. And of course, our strategy regarding corneal transplantation is basically influenced and determined by the results of the anterior segment OCT technique. So in cross-linking, we always measure the so-called demarcation line. After cross-linking, the demarcation line, as you know, is the cutoff point, is an area histologically devoid of keratocytes, indicating the efficacy depth of the cross-linking. And we always try to have as deeper penetration of the UV light as possible in the tissue. So a superficial demarcation line is this hyper-reflective light line that you can see here. The deeper this demarcation line, the better, actually, the more effective the cross-linking treatment that we have performed. And there are other cases when we have formation of haze, sub-Bowman haze after cross-linking, which is also visualized on slit lamp, but the best way to visualize it is actually the anterior segment OCT. Now, sizing of ICL, implantable Coleman lens, is crucial, and we measure the wide-to-wide depth, the sulcus dimensions by using anterior segment OCT again. Here you can see the positioning of the ICL. And more importantly, of course, routinely, most surgeons are just examining the patient after implantation of the slit lamp, where you can assess this space, the vault. So it's the distance between the posterior layer of the ICL and the anterior surface of the lens. But if we have issues intraoperatively or issues after the surgery, then we need to visualize the ICL and measure the vault so that we can actually document the positioning of the ICL. Now, this is a keratoconus patients where we implanted a toric artisan lens, and then intracorneal rig segment implantation was at first place, and then toric IOL artisan lens in the anterior chamber. And unfortunately, 9 months after the second procedure, we had a spontaneous explantation, protrusion of the Caro ring. So this is a Caro ring, which has also been invertedly implanted, as you can see here. So this should have been backwards, and the triangle configuration should have been there, forward. So this ring has been explanted, and here you can see that we have, so this is another Caro ring implantation and an intact implantation, and we routinely document these patients with anterior segment OCT in order to document that we have the correct depth of implantation, which should be roughly 80% of the corneal thickness at the site of implantation. Now, in laser-assisted refractive surgery, of course, we can measure the flap thickness or the residual bed, stromal bed thickness, but this is something that we're not doing routinely. We mostly use anterior segment OCT when we have issues with the patients, such as in this patient. So here we have a typical case of pressure-induced stromal keratopathy, the PICS syndrome or fluid interface syndrome. And you can see the accumulation of fluid in the interface. Zachariadis has showed a similar interesting case yesterday. And of course, for the cornea transplantation, anterior segment OCT is very important, very relevant. This is a case, again, with a perforatic injury. The question was whether to perform a DALC or it was spontaneously sealed, so there was no positive Zydel for this patient. So the question was whether to perform a deep anterior lamellar keratoplasty or a PK. And this is another patient with status after penetrating keratoplasty for keratoconus. And here, this is the graft-donor junction. The graft-donor junction, so this is superiorly, inferiorly. So in the inferior part of the graft, we have an ectasia on the graft with marked thinning. So this patient is on the waiting list for a big repeat penetrating keratoplasty. The lamellar surgery, lamellar endothelial surgery is keratoplasty, is another area where we use more and more anterior segment OCT. Here you can see status post-DSEC. We can check the centration of the graft, make sure this is actually another case that I showed yesterday. Here you can see that the inferior part of this DSEC graft is thicker compared to the inferior part. Okay, and down here again you see the edges of the DSEC graft in the centration. And most important is the DMEC keratoplasty. It's where we need the visualization of the inner, of the interior surface of the cornea. So these are all cases of decimate membrane detachment. As you know, the DSEC grafting is producing an interface, and you can easily see the interface on the slit lamp and also assess the margins of the graft, but with DMEC is different, especially if you have patients with very advanced bullous keratopathy. You cannot always recognize the margins of the graft on slit lamp examination. So you're never, sometimes you're not 100% sure whether the graft is well attached. So this imaging technique allows us to be sure postoperatively whether there's a detachment or not. So I will summarize in form of a take-home message the talk. Anterior segment OCT is a powerful tool for qualitative and quantitative assessment of the anterior segment, very useful for all anterior segment surgeons, corneal refractive surgeons. It's extremely important for the planning of the refractive procedure, also for the follow-up of the patient, assessment of potential complications. And nowadays we have all-in-one solutions, devices performing the imaging, also corneal topography, aberrometry, soon biomechanical analysis of the cornea. And this is actually something that all anterior segment surgeons are welcoming in their everyday practice. Finally, I would like you, as newly appointed secretary of the cornea section in the EVER, I would like to welcome you all to our next EVER Congress in October 2019 in Nice. It's going to be the last time that the EVER Congress will take place in Nice, and we'll be happy to have many abstracts from Greece and actually have Greek ophthalmologists talking on various different topics, particularly in the cornea, which is the topic what I'm doing there. So thank you very much for your attention.